In this lecture, we'll be taking a look at trauma and forensic taphonomy. Prior to the slide that you currently see, I have a number of key points that I want to get into your notes. So as you take notes on this lecture, it's important to be cognizant of things that I mention relating to additional details, things that are not necessarily written down on the slides as we navigate through some of the examples having to do with trauma. And today we're going to, at least in this lecture, we're going to focus on blunt force trauma and some of the kind of physics and physical qualities that are associated with it. But let's begin with trauma and taphonomy. So what is trauma? Trauma is evidence of the modification of human remains. It is a type of taphonomic factor, meaning it is something that should be documented and explained in terms of the condition of remains. So how did those conditions, or how did those remains rather, come to be in the location that they are, and what can we learn historically about those remains and their condition? And that is, again, reading the taphonomy or applying taphonomic principles to the study of human remains. The primary way we can understand, in this case, what is natural and what is not is by understanding something about human anatomy and physiology and human variation. So removing modifications that are in a sense natural or part of a growth cycle from those that appear to be outliers, things that are the result of an abnormal behavior or some sort of unnatural event. And trauma would fit into that second category. So let's define what trauma is then. Trauma is a discontinuity in human tissue that results from a single event or a series of events that result in injury or death. So let me read that to you again. Trauma is a discontinuity in human tissue that results from a single event or a series of events, and that these in themselves will result in injury or death, one outcome or the other. Trauma must not be mistaken for post-mortem modification of human remains, and vice versa in a sense. So if you are dealing with remains that are considered to be composite, meaning they're made up of fragments of other remains, and this happens quite a bit with skeletal evidence, these kinds of composite examples are all post-mortem. They are things that are not necessarily directly relatable to trauma pre-mortem or perimortem. When you think about paleoanthropological uses of fossilized fragments and how we develop holotypes and all of these other kinds of unique specimens that we use for instruction or that we use to talk about human evolution or that we incorporate into comparative anatomy, those are all composites and are things that would not fall under a traditional kind of traumatic heading. The kinds of trauma or the discontinuities in tissue that we see in forensic circles and anthropology generally, like everything else, will fall into a skeletal category for the most part. Fractures probably are the most common type of trauma that is revealed in forensic and archaeological research. It's defined, in this case, a fracture is defined as a kind of trauma. It is a discontinuity in osteological tissue in this case, with or without the corresponding damage to surrounding soft tissue. So the most common expression of trauma that we have in skeletal analysis falls into the category of fractures, perimortem, premortem, and we are focusing very strongly on those fracture patterns and not necessarily looking for any sort of discontinuity in surrounding soft tissue. There are two major categories of fracture that we deal with in skeletal circles. The first is incomplete. So an incomplete fracture is where we don't have any division of tissue that we can directly observe or measure. The other is comminuted, comminuted, comminuted. This is a situation where we have a fracture that is traditionally a division of tissue material into two or more parts. So that does bring us to this first slide. The slide that you are looking at in this case is something that represents a comminuted fracture pattern. We have a very visible, distinct division of tissue, in this case, skeletal tissue. And part of the other takeaway from this initial slide is that the forces involved in fracture, bone fractures, are things that are also important to our work. They help us to explain, in a sense, the event or the series of events that led up to and is the cause of the trauma that we are recognizing in bone. So that's another important piece. Now, in terms of the timing of a fracture, as I've said before, we have really three main categories. We have fracture patterns that are considered to be perimortem, P-E-R-I, para, meaning that this is occurring at or around the time of an injury or death. We have postmortem, of course, that's after, right? Mortem meaning death, post, right? After a death event has occurred, and those are things that can be involved in how people are, in this case, maybe trying to hide a crime. And then ante, A-N-T-E, antemortem, this would be before death. So if there was a struggle, if there was a variety of blows, if a person was trying to fend off blows, and there were fracture injuries associated with that, that would also be something that we could categorize under this time of fracture known as antemortem, or before death. Now going back to the slide we have here, and talking about the physics behind bone trauma, we really have to focus in on one particular kind of, in this case, protein that is typical of osteological tissue, and it's expressed a little bit differently in this case, compact bone, but it is very important. And really, the compact bone is what we're looking at for this particular discussion. The presence of collagen, and generally collagen 2, but we see collagen 1, 2, and 3 expressed in our skeletal system. The presence of collagen in living bone promotes its elasticity. You might think that bone is very, very rigid. It is, but it does have a certain degree of flexibility to it, and it's important. And when you're living, that expression of flexibility is at a much higher percentage than if you have been deceased for quite some time. And of course, there are other taphonomic qualities in terms of the environment in which your remains were interred or left. So the elasticity of skeletal material is important because that's going to tell us something about the degree to which a fracture occurs. And of course, we're very much interested in injuries that were associated with a living period. So those antemortem kinds of injuries are very important for us as we piece together qualities of a criminal situation. The path of fracturing is also very, very important and can vary in terms of the different kind of bone that you're looking at. This diagram here is really an expression of tubular bone, and we see a very high level of collagen expressed in that, but we will see collagen levels vary in terms of irregular bones and flat bones, bones of the cranium, bones of the postcranium, bones of the skeletal, or I should say the vertebral column, bones of the rib cage. It all kind of varies in some degree or in some way or another. In a sense, collagen gives bone its tensile strength or its elastic strength. Now, this is important to archaeological taphonomy because as collagen breaks down, the material that we are looking at, the skeletal material we are looking at, becomes more brittle and weak in relation to the varying forces that surround it. And this can promote decay. This can promote additional kinds of post-mortem injury to the remains by vermin or rodent action, things like that. Injury also causes increased rigidity in bone. Injuries leading to death will often create a 2-week period of time when collagen begins to diminish. You can have healed fractures. These will also become a little more rigid just because the level of collagen in that reabsorption and reformulation of bone is greatly diminished. But generally, at about 2 months after death, the bone begins to slowly decline in terms of this tensile strength, and so it becomes more and more brittle as we move farther away from the death event. Ironically, cranial bone remains elastic the longest before and after death, yet fractures remain visible the longest in cranial material. So impact injuries and cranial bone create patterns of discontinuity on the exterior and the interior of bone material, and we'll be taking a very close look at that in this lecture. Fractures that have a flaking appearance, or what is called a contre-coup fracture, can be found opposite the point of force. So that is another fracturing characteristic that we'll be looking at, and there we will start to take a look at some of the soft tissue that surrounds the osteological material to be able to kind of fill in the gaps there. When we take a look at this tubular example, we have a situation where at the top of the image we have the points of force being established, and then as that bone goes through a process of sustaining that force that's being, again, or is impacting the bone itself as it is attempting to sustain its physical integrity, the tensile strength is being met, and then it is being overcome. And as it is overcoming, or as the tensile strength is being moved beyond what the bone can maintain in terms of its physical force, then we start to see the fracture patterns emerging. So collagen gives a bone its tensile strength. Tubular bone bends and breaks in a very predictable fashion. In this case, we see compression fractions or fracture patterns occurring on one side, while on the other side of a tubular expression of bone, we see tension kinds of patterns where the bone is being torn apart. So, and again, these fracture patterns will, in a sense, vary with regard to where the point of force is and the degree to which that point of force, or the degree to which the force is being exerted on that bone. And then, as I said before, the bone itself. Here is another slide. It gives you an idea of a humerus. The humerus itself is something that is tubular in nature. We know it's a long bone of the upper arm, and so it provides us with this kind of characteristic break pattern. If you take a look at this more closely in terms of the slide, we get a sense of the direction of the force. This is a type of force known as blunt force trauma. So this is associated with any sort of object that does not have a linear or ridge-like blade to it. That would be more sharp force trauma. And there are hatchet classes within the sharp force trauma category. Ironically, and something we'll be taking a closer look at, gunshot wounds are considered to be under this category as well, because again, they don't have any sort of specific ridge. They are tumbling through an environment, or they are kind of translocating through that environment in a very linear fashion, but yet the damage they're doing falls under the blunt force category. So when we take a look at this humerus, we realize that the large arrow is giving us a sense of the direction of the force, and then we see a fracture pattern, an initial fracture that is going from that point of impact outward, and then we have those kinds of kind of stress fractures on the opposite side of the bone that are associated in this case with a secondary kind of fracture pattern that moves in a superior and lateral fashion toward the shoulder region. And then we have the development of a bone spur, which usually will point back toward the point of impact. And again, this is very much characteristic of tubular bone. And so this is an injury that occurred while the person was raising their arm, attempting to prevent the injury, and they were struck just inside of the arm, so on that medial surface of the arm, and then the force continued through the arm like that toward the lateral side or toward the outside edge of the upper arm. So again, this gives you an idea of how this process works, and this would be ante mortem in a sense. It's happening just before a death event. So in the next slide here, we're going to be taking a look at cranial injury, and it will bring up a few other ideas having to do with any sort of impact injuries. And what develops in terms of soft tissue and what develops in terms of hematomas. So the presence of related soft tissue injuries and the blood matter that's associated with them, again, usually focusing on a point of impact, relates to the formation of what is referred to as a hematoma. The degree, the size of the hematoma is very, very important. It can be really part of the timing event when we are starting to understand something about the injury. In terms of trauma itself and this developing hematoma, there is another important consideration to make, which is the development of a fibrous callus. So a fibrous callus will often be associated with the periosteum that surrounds and in a sense provides blood resources and protects the compact bone surfaces of many of the elements within the skeletal system. A fibrous callus will also, in a sense, develop usually on the surface of the bone. So if you have ever injured your bone and have a bone bruise and you feel just deep in the soft tissue, just above where you have injured yourself, kind of a almost what appears to be almost a hard structure that has developed, but then eventually goes away. And there will, of course, be bruising, the hematoma associated with this. This is the development of a fibrous callus, and this really identifies the specific point of force. The callus is a physical connection between the soft tissue and the damaged bone. It goes through a process of even forming a kind of calcification or helping to protect and allow for the development of new bone if the bone itself has been damaged. So it does play an important physiological role in this. Now when we take a look at this cranial trauma here, what we're seeing is, again, a blunt force trauma type. This is a hammer class of blunt force trauma. In fact, it was a hammer. The blunt end of the hammer was being utilized to strike this individual from behind and slightly to the left of the individual in this case, or the victim. The fracture pattern that we see here again is typical of a hammer type injury. You get these very unique concentric fractures that demonstrate the collapse of the bone, and we'll be talking a little bit about the stages of physical breakdown as it relates to the bone itself. And these concentric fractures will be part of that. And then from the kind of actual point of impact, we also see radiating fractures. These are a little bit harder to see, but they're almost internal to the injury, and they have almost like a web-like or spider-like, often deep and linear pattern to them as well. Just to the base, or to the kind of south of the circular injury, you can see what's left of the hematoma that covered this entire area, and then of course above that there was the development of a fibrous callus as well. So, and again, this is a parietal bone that parietal eminence that you were looking at in terms of identifying bones of the skull. This is just uh, posterior and slightly medial to that eminence. And so the individual was definitely not looking at the perpetrator when this fatal strike occurred. And it caused unconsciousness and a brain bleed that led to their death. So when we look at fracture sites, and we're going to take a look now at another cranial injury, when we look at fracture sites, in a sense, we are seeing not only the injury to the hard tissue itself, but then we're looking at what happens with regard to blood flow in the area and this coagulation that occurs as the body attempts to repair itself or prepare to repair itself. Now, fracture site coagulation of blood and other fluids for humans occurs within a 6 to 8 hour period of time after the initial injury occurs. This includes cellular inflammation, so a lot of various physiological materials, including fluids, rush to the site to be able to protect that damaged area. And this inflammation represents the body's attempt at repairing the external periosteum of the bone matter, or this external covering that's important for the bone health and for the living bone in a sense. The repair process is important. It's very, very rapid. And it will be most rapid with individuals who are of a younger age. So if you have an individual who's a child, somebody who's not sexually mature, for example, the rate at which this coagulation and inflammation occurs will be at a much, well, it will be much more rapid than what we see with adults. Bone repair can occur within 6 weeks of injury. It can take 6 months, as many of you are maybe aware of if you have ever injured an arm and had to wear a cast. The longer, of course, for the adults. So in this particular image, what we see here is a multiple comminuted fracture pattern, again associated with blunt force trauma. We have those very characteristic concentric fractures of the hammer type blunt force class. We also have radiating fractures, and of course we have a sense of where the center of the injury generally would be. We're not looking per se at hematoma or any sort of, in this case, developing fibrous callus that's been removed, but we get a sense of kind of what's encircling and encapsulating those injuries. And what we realize is because it is so complex, we are dealing with an event that had two strikes or two blows. And so the individual is, again, being struck from behind on the right side this time. They're twisting and falling forward, and then they're being struck a second time in a pretty rapid fashion for that second blow. And they've numbered the blows here for you as well. So from the side there, and but again, in that that right location, a pretty hard blow, and then as the person's falling forward, a secondary blow there as well. And so this is a pretty extreme version of a blunt force event. Before moving on any further with some of these examples, let me build a few ideas back into your notes having to do with fracturing forces. And I will then tell you when we're going to kind of switch over and look at another comminuted example, in this case, fibula. So fracturing forces, we really, in terms of looking at bone and bone structure, recognize four of them. We recognize bending forces, we recognize shearing forces, we recognize torsion, and we recognize tension. So bending, shearing, torsion, tension. And again, these are not in any particular order, but those are the various camps or categories that we place them into. Now, often these forces have very close relationships with the section of the body that receives the majority of the force, in this case the bone type, and of course the amount of surrounding soft tissue associated with that site. Force that is applied to the axis of the body, for example, resulting from things like falling injuries or crushing kinds of impact injuries. These will give us a lot of compression fractures, which in a sense are combining or blending together, in this case, both the bending and the torsion kinds of forces. But a compression fracture is something that is a little bit different because it's associated with more vertical force, whereas when something is coming from the side, we find that there are shearing and tension fractures, and those are very often resulting in depressed fractures of the kind that we were seeing with that hammer type class for blunt force trauma. In this case, again, we're dealing more with a pretty interesting crushing injury. It is comminuted fracture patterns associated with the left tibia. This is a kind of a falling injury to the leg. These comminuted fractures are complex, and you can see that it's very, very hard to kind of reconstruct these particular kinds of patterns, but they fall into that kind of compression crushing class. And again, it's associated with a fall in this case. And again, back to a cranial injury here. Again, a hammer type class of blunt force trauma. This is giving us some of those depression fractures. They're concentric in nature. These are pretty deep, and very much are resulting in kind of the termination of complete termination of tissue, and literally in this case we're having even bone fragments jettisoning into the endocranial region. But this is an injury, again, left parietal bone, blunt force trauma. A bone plug develops in this kind of after this depression occurs and after we get these kinds of deep concentric fractures. And we are looking at it from the exterior of the skull, so the ectocranial surface, but we realize that there's a lot of damage occurring internally, and which results again in brain hemorrhaging and different kinds of hematomas on even the surface of the brain and the space between the brain itself, and the mesentery and the literal surface of the bone that is being broken. So again, a concentric fracture, and one that has pretty extreme depression fractures associated with it. Again, another blunt force example. Here we have a cranial bone, again with pretty extreme depression fractures and concentric fractures. We have multiple wounds, so this is kind of a multiple event, or there's a series of events that are occurring here. But you can see at kind of the center, slightly off center portion of the photograph, there is a pretty extreme initial injury, and it fits into that both blunt force traumatic group, but then also that hammer class. And then as the person is falling, you're getting some of these less forceful injuries as the person is tumbling and falling forward. And as I said before, the injuries when you're dealing with cranial trauma are not always visible only from that kind of ectocranial surface. Cutting or during autopsy, when they develop that calotte or that kind of cap where they're literally cutting the top of the skull off to be able to look internally and examine the brain. This is something that will also reveal some of the internal damage and structures. Here we're looking again at that endocranial surface. At the top of the photograph, you're seeing kind of the thickening associated with the occipital bone. And then at the bottom of the photograph, and of course it's been modified as part of the dissection, we have the frontal bone. And what you're looking at here is you're looking at that endocranial surface and the development of that bone plug that will jettison into the cranial cavity and cause some pretty extensive damage there. The additional arrows that you see in the photograph, and everything has scale associated with it, these are demarcating rather, a natural linear or spider-like but deep fracture that's moving away laterally, both left and right, from that initial point of blunt force impact. And now a couple postcranial examples of developing fibrous calluses. Here we have pretty extreme events. So we have again a fibula that has a pretty significant fibrous callus that has developed on and around the linear break, which resulted in a complete break of that bone. On the right hand side, we have a femur. We are looking really at that lateral surface just below the neck of in this case, proximal portion of that long bone. And here we have this myostesis ossificans. It's a kind of developing callus due to extreme hyperextension of some of the ligament attachments that are, again, associated with not only the kind of inferior portion of the pelvis, but even the sacrum and coccyx and the muscle attachments then with the and surrounding the head of the femur. And this was drawn from a case where you had pretty extensive torturing going on. So this was the result of a hyperextension and ultimately a dislocation of the right femur as the individual's, their leg was being pulled out of joint, and we had the attachment points for both muscle and so tendons and ligaments that were resulting in this pretty extreme callus formation directly on the bone surface itself. So again, these are all characteristics of trauma that help us to reconstruct an injury and determine whether or not that injury was something that would have been fatal. So again, all of these characteristics also relate very closely to blunt force kinds of injuries. We will look at sharp force trauma very soon. But to round out this initial lecture on trauma and the skeletal system, I wanted to get into your notes four physical events, which are things that really are occurring rather, at the bone level. And they result in a lot of the different kinds of fracture patterns that we've looked at thus far. They will incorporate ultimately a lot of the fracturing forces that in some combined way that we've also briefly looked at. So let's get this into your notes. So this is a series of physical events which occur as the trauma unfolds, and I'm going to use cranial bone as an example for this process. So number one, or the first thing that starts to happen when, if you think of this in slow motion, the blunt force object or the blunt object is coming into contact with an individual. First, you have an initial bending of the bone inward. So this is where that tensile strength becomes very, very noticeable. And if you think of some of these slow motion videos or films that you have seen, and if you've ever seen an impact of one object onto or into another, there's always that little bit of give on the one that has maybe more of an anchor to it or is more stable. So first there's this initial bending in of the bone. So if you think of the surface of the bone, it starts to literally bend inward. Think of it like a sandwich if you're thinking flat bone. You have the compact bone on the outside. And when this bending occurs, the tensile strength of that compact bone surface is being challenged. And what we see in terms of fractures is the development of stress fractures, but they're compression stress fractures that will start on the outside of these bone layers. Next, or second, the tensile strength begins to build. So the actual tensile force starts to build internally. So if you think again of the cranial bone as a sandwich, right? You have compact, diploid or spongy bone, and then compact in terms of that layering. Inside or between those compact layers, above and below, you start to have the development of a source or a point of tensile force internally. So it builds on the interior of the bone and it starts to move outward. So fracture patterns begin to develop internally and then they travel back toward where that point of force is occurring on the very exterior of the surface. Third, concentric fractures begin to appear on the external surface of the bone and they surround the point of impact. So our mental camera goes back up to the outside of the cranial bone, specifically that compact bone layer, and you look at where that blunt object is striking not only the soft tissue, the scalp, damaging, and we'll talk about that in a later lecture, damaging the scalp and what lies below it. But then on the bone surface itself, below the periosteum, these concentric fractures, these circular fractures start to form of the kind that we saw before in some of those images, and they surround that point of impact. So that's number 3. So let me just review that real quick. So number 1, bending of that bone surface, the external surface inward, compression, stress fractures on that outer layer of bone right under the point of impact. Number 2, tensile strength starts building, or tensile forces start to build internally. These will move back toward the point of injury and cause linear fractures, again, directly underneath that blunt force region. Number 3, concentric fractures now start to emerge around the surface of impact, almost as if you're drawing a circle around that point of force rather. And then fourth and finally, you have the additional kind of beveling and collapse which occurs at the surface with depression fractures. So if you were to think back to, for a moment, the cranial injury that we first looked at, and I've brought that up as you can see for you to look at again, these beveling kinds of collapsing qualities of that compact bone on the surface can be very visibly seen as bone fragments develop and then they collapse inward as the bone itself, at least the outer two surfaces, well, I guess the outer surface and the internal surface, that spongy bone, as that all starts to condense down. And that collapse, if the force is great enough, can then work its way to that final layer, which is part of that endocranial surface, and that can then jettison, if it's strong enough, inward. But if you take a look at this particular slide, you can see again where B is, it has these kinds of concentric fractures that are sloping down as almost the development of almost like steps. If you think of an escalator at a mall or at an airport, you have this flat surface, but as it begins to kind of move kind of downward, and it's moving over, in this case, no longer a flat surface, the development of the stairs that you walk on, that occurs. It's a wonderful design, but in this case, that's kind of what's happening here. These stairs are developing from the bone fragments as they are breaking and kind of slumping down into and toward not only the injury, but the central point of that injury as that fracture pattern develops. So again, 4 kind of stages to the development of an injury, in this case a bone injury associated with blunt force trauma. You'll notice when we get into it that this is going to be different from sharp force trauma, but it will have some similarities with regard to gunshot wounds. And so we'll save that for a later lecture.